More from eCancer TV now with Professor Johan Vansteenkiste from Leuven. Johan, you've been talking yesterday, you were chairing a meeting. It's a little bit complicated, but it was all about staging, integration of staging procedures. Now, what occurs to me is that this isn't very easy. Did you get any clarification from yesterday's meeting?
You're right. It's the patients that do not have metastasis, only local or local regional disease. It's quite a heterogeneous group, and sometimes treatment decisions are complex. And so one of the tools to have good treatment decisions is it starts with a good staging of the patient, determining the TNM stage as precisely as possible. Also the resectability, if the disease is amenable to surgery. And for these decisions nowadays, this has really become a multidisciplinary process with input of many disciplines.
Now, in non-small cell lung cancer and early and locally advanced disease, what things are emerging as key in this staging procedure?
Well, certainly with a large randomized controlled trial published last year, one thing that is emerging, that is we have improved our imaging methods with CT scan and PET scan, but for verification of the pathology of the disease, the endoscopic method with endoscopic ultrasound, either by the bronchus or the esophagus, has become very important in our armamentarium. Actually, the randomized controlled trial I talk about, found that if you start with that endoscopic type of staging, and you do only a surgical type in a limited number of patients, that you're better off than what we did in the past with the surgical staging only. So it's an integration of imaging, endoscopy and surgery, and certainly what has moved forward in the last years dramatically is the endoscopic part.
So what sequence of events should there be for the patient presenting?
Well, indeed, there was discussion at the session yesterday, but many of us now believe that the optimal imaging method is a combination of a PET-CT, and then you use your endoscopic staging first, and this will be sufficient for many patients. In case of negative findings, you should verify by a surgical method. But overall, this has really made the staging process more straightforward, less invasive for the patient, and it is a substantial benefit, I think.
Now, there are several different categories. Could you summarize what are those key categories and what are the different therapies that would result from the staging conclusions that you come to?
The main issues are you have patients that don't have diseased lymph nodes in the mediastinum, and on average, if they are fit enough, they go to surgery, straightforward. And then you have patients with lymph nodes in the mediastinum. And to make it a bit simple, there are those with a moderate amount, a more limited amount of lymph nodes, where surgery probably plays an important role in the treatment approach. It will always be multimodality. It will incorporate chemotherapy, surgery, perhaps radiotherapy. And you have others where the lymph node disease is so important that it's no longer possible to achieve complete resections. And there you don't need to insert surgery because it doesn't help, it may actually harm. And so the whole staging process is about dividing these three types, the ones with straightforward surgery, the ones where surgery may play a role in the combined modality setting, and the ones where surgery doesn't play a role.
And to what extent are the newer therapies changing this picture about which treatments you use and how important staging are, the targeted therapies, for instance?
Well, the new staging methods have brought more detailed, what is often called mapping of the lymph nodes, where exactly and how important that lymph node metastasis in that patient is. And it's by distinguishing these categories that you try to divide the complexity in different treatment paradigms, surgery only, surgery has a role, surgery has no role.
Now, if you get the staging right, can you map out the optimum strategy for each individual patient?
Well, as always, with the limitation of medical evidence, there is ongoing discussion, and discussion usually leads to progress, so that's not a real problem. It's good that there is discussion. So a lot of things have been sorted out. For instance, for the surgical patients, you often add additional chemotherapy after surgery. For the patients that don't go directly to surgery, you use combined modality, usually including chemosurgery, perhaps radiotherapy. And you have the non-resectable ones where it's clear that you should give concurrent chemoradiotherapy. So things have been sorted out. What is still a matter of discussion is, well, where are the limits between these categories, between these three categories?
And how much better is the staging and the individualization of therapy if you use a fully multidisciplinary approach?
Yes, well, the word you use is very good. It's individualization of treatment, and I can make the parallel with patients with metastatic disease. There we try to individualize based on molecular characteristics. What you do in the patients with non-metastatic, with localized disease, is you try to individualize based on staging and resectability characteristics. And this is, I think, with all the new tools that we have now compared to 5 or 10 years ago, where we really can individualize and based on a multidisciplinary board, because as you said in the beginning, it is complex. That's why you need the input of a multidisciplinary board, the pulmonologist, a surgeon, a radiation oncologist, a medical oncologist, an imaging specialist. And yes, I think you can make the difference there for some patients.
The difference, I mean, how big a difference is that likely to be if in an ideal world?
Well, that's difficult to estimate. I think if you give the same treatment for each of these individuals, you will probably stay with a cure rate of 15% in the more advanced local patients. I think if you individualize, you can put it to 25 or 30%.
Well, those are big figures.
Yes.
And you're responsible now for the Lugano consensus, so you're one of the big contributors to the Lugano consensus on early and locally advanced non-small cell lung cancer. What is your conclusion?
Well, quite appropriately, it's a multidisciplinary group with all the disciplines that I just mentioned. The conclusion is that there are still much controversies, and we will try to make a document which makes the best junction, the best bringing together the medical and evidence on the one hand, which is limited, and where there are gaps, and the multidisciplinary board experience where you may address some of these gaps. That's what we will try to do.
And in practical terms, finally, what would you like to see doctors doing right now?
What I would like to see is that the more complex cases is that they are always discussed in a multidisciplinary board where all these disciplines are present, and probably there is an advantage of people working together there in larger units where experience is the real life experience on larger number of patients. And I think that certainly would be a benefit for the patient, having a real multidisciplinary board in an environment where there is large experience.
Johan, thank you very much for being with us on eCancer TV.
With pleasure.